Thank you, Jeannie. I hope you had a nice coffee break. So first of all, I would like to thank the organizing committee for inviting me today, and I have nothing to disclose. So actually, Jeannie gave me many objectives. I'm not the one who wrote this up. So my objectives are first to describe differences between weak D and partial D. Second, to discuss practical aspects of genotyping testing and discuss when we should give NTD prophylaxis to patients with weak D. And finally, we will study 3 different clinical cases so that we can know when to order genotype testing. So first, let's go back to the Rh blood group system. So the Rh blood group system comprises 56 antigens as of June 2021, when the ISBT published their latest list. These antigens are encoded by 2 genes, the RhD and RhCE genes. They are both located on chromosome 1, and they each have 10 exons. They are in opposite direction with 3' ends facing each other. There's also a 3rd gene that is called the RhD gene. It is located on chromosome 6, and it encodes for the Rh-associated glycoprotein, RhD, which is essential for the expression of the Rh gene, antigens, sorry. But today, we will focus our attention to the D antigen. It is also called Rh1. So its prevalence varies according to ethnicity. In Caucasian, approximately 85% of patients or people are D positive, whereas it is approximately 92% in Blacks. And in Asian and Native Americans, it's a high prevalence antigen, so almost everybody is D positive. The D negative phenotype is characterized by the total absence of D protein from the red blood cell membrane. In Caucasian, it is caused by the deletion of the Rh genes, whereas in Blacks, it is very frequently caused by an inactive RhD genes that we call the RhD pseudogene. The D antigens is expressed on cord and adult red blood cells, as we've seen previously. And as you all know, it's highly immunogenic, so it can cause mild to severe HDFN, and it can also cause mild to severe immediate or delayed hemolytic transfusion reaction. So there are more than 100 mutations that has been characterized for the D antigens, some of which can cause weak D and partial D. So let me explain the difference between the two. So weak D occurs between 0.2 to 1% of the population, depending on which reference you're looking at. And it's basically a quantitative defect where the mutation will call for a decreased amount of the proteins on the red blood cell membrane. So basically, you have a decreased antigen density. Partially is a little bit less frequent, around 0.2% of the population, and the mutation encodes for a qualitative defect. So there are either missing epitopes or the mutation will code for unaltered proteins. And this protein can be recognized if you're partial D, if you are exposed to normal D antigens, you can recognize this antigen as foreign and from an NTD. So what does it mean in practice? If you're a weak D, you have a normal D antigens, but in decreased amount, you will not form an NTD, and you will not be at risk for HDFN. So these patients should be considered as D positive. Consequently, you can transfuse them with D positive red blood cells, and pregnant patient would not need RhD. On the other hand, partial D is at risk of forming an NTD, so there's a risk for HDFN. So these patients should be considered as D negative, and they should be transfused with D negative red blood cells, and they do need RhD when they're pregnant. So how do we recognize them in the blood bank? So typically, weak D will present with weak reaction. So that we grade the reaction from negative to 4+. So we usually consider positive reaction as 3+ or 4+, and those who are 2 and under are considered weak. And we can actually do the weak D test to enhance those reactions, and I will get back to this later, but it's not routinely recommended. But we have to be aware that the strength of reaction can vary according to the anti-D reagent you're using or the technique you're using. For example, if you're using a gel column technique, it's more sensitive than the tube testing. The partial D, historically, you would find a normal strength reaction. So the patient would type as a 3+, 4+, and you would say that patient is D positive. But if this patient is exposed to to a normal D, either through a blood transfusion or pregnancy, then there's a potential for forming anti-D. So historically, those patients would be typed as D positive and come back later, and we would find an anti-D. So because they are at risk of forming antibody, we should transfuse them as D negative. You need also to know that the capacity of an antiserum to detect a partial D is quite variable. For example, in the US and in Canada, the monoclonal reagent we use to do the D typing do not detect partial D type 6, which is the most frequent in Caucasian. So if we do the routine D typing in tube, it will react as negative, and this patient would be considered as RhD negative. However, if you use other reagents, not the current one, but in other countries, those patients could come up as D positive. So in the last 3 slides, I depicted partial D and weak D as 2 dichotomous entities. But in fact, it's a little bit more complex than that, because we know that there are some weak D that can form antibody, and there are also partial D for which no known alloantibody have been described. Maybe because they have not been reported, but it could also be because there's no risk of forming an antibody. So actually, we should move away from this nomenclature of partial D and weak D, and many authors have proposed in recent years to refer to them as D variants. So in practice, it means that we should move away from the nomenclature based on serology and move to a nomenclature that is based on genotype result. So before going further, I will expose 3 real-life makeup scenarios. So, and we'll discuss this a little bit along the road. So the first patient is Kim. She's a 16-year-old patient from whom a group and screen was requested by the physician before a surgery for scoliosis. So she's group A, straightforward. When we do the D-typing, she is 1+. So according to the blood bank policy, they tested with a second antiserum, and this time she's 3+. So you see that there are different strengths of reaction for the same sample. What should we do? Second case is Anna. Anna is a 28-year-old pregnant patient. It's her second pregnancy. She's 11 weeks pregnant. So during her first pregnancy, she was followed in Ontario. She was O positive. She did not receive RhD. But she crossed the Outaouais River, and she is now followed in Quebec for a second pregnancy, and first analysis in Quebec, and now she's O negative. So we have discrepant RH group. How can we explain this? We'll get back to this later. And our third case is Mary. Mary is a 64-year-old patient. She had no history of previous pregnancy. And she was typed as AB positive in 2016. She received 2 units for surgery. Her screen at that time was negative. And then she come back because she has been diagnosed with an acute myeloid leukemia. We repeat the type and screen. She's AB positive, but now we see an anti-D. So how can she have an anti-D if she's D positive? You should know the answer by now. So actually, we're quite lucky because 7 years ago, there was a joint working group from ABB and CAP who published recommendation on RhD genotyping for patients with serologic weak D phenotypes. So their recommendations were threefold. First, they recommended that we should perform RhD genotyping whenever we had an inconclusive or discordant RhD typing result and or serological weak D phenotype detected in a female with childbearing potential. They also stated that person with RhD type 1, 2, or 3 should be managed as Rh positive because these patients are not known to form NTD. So it would result in fewer unnecessary injection of RhD, and we could also increase the availability of Rh negative red blood cells for transfusion. They also recommended that in order to facilitate implementation, we should do large-scale testing, and those samples should be sent to reference lab performing red blood cell genotyping at an affordable tier service. So at the same time, they published an algorithm. So basically, I will walk through, I will explain it. So if you're D negative by tube testing or immediate spin, you're a candidate for RhD, and you should be considered as RhD negative. On the other hand, if you have a clear positive reaction 3+4+, you should be considered as RhD positive, and you would not need RhD during your pregnancy. However, if you have discrepant or inconclusive or strength of reaction, then you should be, your sample should be sent for RhD genotyping. If your genotype reveals that you're type 1, 2, or 3, so the green box, you're not at risk of forming an NTD, you're not a candidate for RhD, and you can be safely transfused with RhD positive red blood cells. On the other hand, if your genotype reveals that you're something else than with the type 1 or 2 or 3, you should be managed as an RhD negative patient. In 2020, they updated their recommendation to add RhD 4.0 and 4.1, and they stated that these patients should be managed safely as D positive with regard to blood transfusion. However, they added this line, which is quite, what do we do with this? They basically said that for pregnant women with a RhD type 4.0, consideration may be given for D negative transfusion and RhD for the immunoprophylaxis in an abundance of caution. So what does it mean? So we know that for RhD type 4.1, there's no risk of forming an NTD, either an allo or an autoantibody, so it's safe to consider them as RhD positive. However, for 4.0, there have been 38 cases of NTD in the literature. It's not always clear if these are auto or allo NTD. But in the US, the RhD type 4.0 is very frequent in African American patients. And since there has been no case of HDFN or hemolytic transfusion reaction, they stated that we could consider them as RhD positive because transfusing those patients with D negative blood would put a burden on their inventory. So the context in Canada is quite different. We don't have such a huge population of Black patients. So at the time, both Héma-Québec and Canadian Blood Services, and I would say experts throughout Canada, suggest that we should continue to consider those patients with RhD type 4.0 as D negative. Now, we're quite lucky actually that we have Canadian recommendations. So the NAC just updated a few days ago their guidelines for RhD genotyping in prenatal patients. And there's a similar document in French for the province of Quebec that was written by the CCNMT, which is the NAC equivalent in Quebec. And basically, those guidelines are quite similar, and they recommend to consider patients who are RhD type 1, 2, or 3 as D positive. So very similar to the 2015 publication. So now I will walk you through the different steps if you want to request a genotype test. So as said earlier, it should be offered to pregnant women or female with childbearing potential less than 45 years of age. If they have a discordant or inconclusive RhD typing or serological RhD, their sample should be tested to the reference lab. So I would say for the reference labs, the earlier we get the sample, the better it is. So if it can be done, I would say by the end of the first trimester or beginning of the second trimester, that's probably the ideal time because it gave us ample time to send back the results so that you know if you need to give RIG at 28 weeks or if there's a bleed. So as I said, there are 2 reference labs in Canada at CBS and at Quebec. So both will perform the genotype typing, and I will explain the difference between the 2 in the next slide. And then the reference lab will send the result to the requesting hospital. They will enter it into their blood bank LIS and send the result to the treating physician. So on the slide, I illustrate the difference between Canadian Blood Services and Quebec, but basically it's quite similar. So at the time being, CBS uses the Immucor RhD molecular bead chip test to do the RhD genotyping. This platform utilized 35 genes, genetic markers associated with the phenotype. Quebec is moving toward the same array, but for the time being, we're using manual technique by RFLP and SSP to detect week D 1, 2, 3, and 42, and I will discuss 42 in the next few slides. For the rest, it's basically the same thing. So we request that the sample be one tube, 2 to 7 ml in EDTA tube. It must be shipped on ice, and CBC requests that the tube arrive to testing site within 48 hours. The usual turnaround time for both reference time is within 2 weeks. And as I explained earlier, the result will be sent to the requesting hospital. There's a slight difference in Quebec because all the blood banks in Quebec share the same LIS through what we call the transfusion summary. So once an hospital writes, for example, that patient A is weak D type 1, it will be available to all other hospitals in Quebec, which is really an advantage if the patient travels around. And then obviously the testing sites are not the same, in Moncton for CBS, Montreal for Quebec. We're fortunate that both CBS and Quebec reported the experience recently. So I will begin with the experience from CBS. So CBS has been offering prenatal diagnostic testing for 4 provinces in Canada: Manitoba, Saskatchewan, Alberta, and British Columbia. And they reported their experience from April 2011 to December 2014. So from 2011 to 2014, they were using the Progenica platform by Grifols. And in 2014, they implemented also the bioarray or the Immucor platform. So some patients were tested with the Immucor platform. So roughly they had they were using the prenatal D typing algorithm that you see on the left of the slide. So basically it's based on the reaction you get with 3 different NTD reagents. I won't go into much detail. The algorithm has changed recently, but basically that's what you see. So they tested over 600,000 patients, of which 79,000 were D negative. Of these, only 0.4% met the criteria for genotyping. And when we look at the different prevalence, 61% of patients were weak D type 1, 2, or 3. Another 33% were other variants. And there were 11 cases for which the case could not be resolved, but it's a minority. So I hope when I report it, okay, good. In Quebec, we had a different experience. So in 2016, the recommendation from the CCNMT were published. And basically, we asked all labs who had discordant or inconclusive or weak D result for female with childbearing potential. They were not pregnant. Not all of them were pregnant. So if you have a 10-year-old, for example, that shows up with a weak D, you can send a sample. And we reported last year our experience over a 4-year period, so between 2016 and 2020. So a total of 2,105 patients were genotyped. And we also compiled the result of the OSPOR, their serological results. So what I want to show you, and I'm not sure I can have the pointer. Oops, sorry. Okay, so you can see that for same patient, and those are OSPOR's results, that some patient had weak reaction, so equal or less than 2+, then when they were typed with a different reagent, some could give 3+ or 4+. So it's a good reason why we should always use 2 different NTD reagents if available. Also, what we can say from this data, I would draw your attention to the third bar. So this is weekly type 3. So you see that in the lower graph, these are the results when we do the testing in tube at immediate spin, so room temperature. And basically, you see that close to 95% of patients with weekly type 3 type as weekly. So reaction strength less or equal to 2+. However, those same sample, if you use a gel column technique, only 25% of them type as weak D. So 75% at 3 or 4+ reaction. Quite interestingly, we have a different proportion of weak D than CBS. So weak D type 1, 2, or 3 represent only 27% of our patients. The most frequent RhD variant is type 42, and this is probably due to a founder effect. So if you look at the map, you see that the areas that are darker, are locations where we find many hereditary disease, like tyrosinemia and some rare disease. So there's probably a founder effect in the Saguenay-Lac-Saint-Jean. And that's what you can see on the graph. So the first bar represents Montreal and Laval, which are multi-ethnic area. And you see that that type 42 is not well represented. However, if you go to the last column, this represents the Saguenay-Lac-Saint-Jean, and close to 50% of the population is RhD 42. Also quite interesting, if you look at the graph here, you can see that RhD 42 is almost, actually it's absent in patients who reported as being Black, compared to a significant proportion for patients who reported themselves as Caucasian. So I think it's important for reference blood to know its population, because it can vary. And D variance varies a lot according to ethnicity. So it's very important for us to know what is the ethnic background of the patient we're studying, because it can orient us toward different diagnoses. So what should you do if you're faced with a patient who has a bleed and you don't have yet the result from your reference lab? Should you give RhD or not? So I think the first thing is maybe give a call to your reference lab. Maybe the result is available and has not been faxed yet. We should move away from the facts, but still. If the result is not available, then you should give RhD based on a precautionary approach. There are some cases of partial D, case of hemolytic disease of the fetus of the newborn reported in the literature in patients with partial D. So if you do not know, go on the cautious side. However, I have to be honest with you and state that there is no clear data in the literature to evaluate whether RhD can prevent alloimmunization in patients with partial D. However, I doubt that we will have some robust data at some point, because one, these are rare, and it wouldn't be ethical to ask those patients give RhD to one group and not give RhD to the other group. So we probably will never have any good data. So let's get back to our 3 cases. So you remember Kim, a 16-year-old who had different strength of reaction. One NTD gave a 1+, and the other one gave a 3+. So she was sent for genotyping, and the genotype result confirmed that she's weak D type 1. So you should know by now that she should be considered D positive. The second case is quite interesting. So Anna tells her new obstetrician in Quebec that she is definitely OPAS. She didn't receive RhD during her first pregnancy. And then she takes her wallet and she shows you the card from CBS stating that she's O positive. She's a regular blood donor. She knows she's O positive. So how can that be? Well, in Quebec, it was the first time they had this patient, so they asked for another tube to make sure that it's the right blood in the right tube. And then they type with the first reagent, still O negative. They do the analysis again with a second reagent. The technologist says, so I'm not sure if it's negative or very weak. Then she asked her colleague to look at it. Well, so I think it's negative. So it might sound a bell to some of us who work in the blood bank. So, of course, her sample was sent to Quebec for genotyping, and she comes back as a partial D type 6. So, the hospital gave a call to the Ottawa hospital. Said, well, you know, when we did the test in immediate spin, she was O negative, but our policy is to do weekly testing. And on weekly testing, she was O positive. So that's why we said that she was O positive. But of course, this patient has a partial D, and she should be considered as RhD negative. So I just want to explain what we do in the blood bank. So when we do, I will go with the classical tube testing at room temperature. What we do basically is we expose the patient red blood cells to an NTD reagent. We centrifuge and we look for agglutination. So as I said earlier, the strength of reaction goes to negative that you have on the left side to a 4+ agglutination that you have a picture on the right side. So the reagents we use now are a monoclonal antibody that will react only, there are IgM monoclonal antibodies that react at room temperature. However, we have blend mixture that contains a blend of monoclonal and polyclonal antibody. And the polyclonal part of the reagent will react at 37 degrees Celsius. And that's what we test when we do a weekly test. So basically, when we do a weekly test, we take the patient red blood cell, we expose them to the NTG reagent. The antigens will bind to the red blood cells. So we incubate for 30 minutes at 37 degrees. There might be some variation, but roughly this is it. And then we wash the red blood cell to remove any unbound NTD. And we'll add antiglobulin, human antiglobulin IgG, and those will bind to the NTD and agglutinate. So the only indication to perform a weekly test is for blood donors. So that's why Anna, she was O positive, because we want to make sure that the blood is well identified, so not to form not to put the recipient at risk to form an antibody. And for infants born to Rh negative mothers, because if an Rh negative mother has a weekly baby, she should receive RhD prophylaxis. And finally, the last case. Well, I'm sure you've guessed that she has a partial D, and that's why she developed her NTD. So if we follow the recommendation, we would not perform a genotype for that patient. She's not of childbearing potential anymore. She already has an NTD, so we should transfer her with RhD negative. But let's say we do it academically. So she's a partial D, type D5A. So in conclusion, persons 50 years old and under with childbearing potential should be genotyped whenever inconclusive or discordant RhD typing result and or serologic weekly phenotype is detected. And samples should be sent to IRL with genotyping expertise. And persons with weekly type 1, 2, 3, and 4.1 should be considered as RhD positive for transfusion and are not candidate for RhD. And weekly type 4.0 is still controversial, as I said. And I hope this talk will highlight or bring some discussion regarding statement 3, which states that weak or variably reactive D reaction in pregnant patients should be investigated with RhD genotyping. Serology weak D testing should not be performed. And I would like to thank my colleague, Dr. Bonner from CBS, who shared some critical information with me, and Gabrielle André Leva-Torres at Thank you.